thanks so much for supporting our digital discussions in January. And this is a little bit of strategic marketing for you and your firm, because you've got a big milestone that you're celebrating and some other things that are going on. But tell us a little bit about the option group and what's happening this year in 2021 with you guys.
Yeah, we got lots of things going on. Thanks, Steve, for having us. I appreciate that. The option group is celebrating our 10-year anniversary. So it's been a great ride. We're expanding now. We have gotten new office space here. Just started in the beginning of January, so we all can be together, but we have lots of space to be socially distant. But one of the things that we do best with our team here of nurses and social workers is that we are able to collaborate really well. We counted it up the other day that we have a collective clinical experience of 265 years here at the option group. So when you get one of our care managers, they have the ability to tap into that robust experience from our whole team. So we're excited to be kind of back together in the same area, and we welcome anybody to give us a call and come visit. But we've expanded with space, and we've also expanded into Pennsylvania. So we provide the same services that we provide in Maryland, up to Harrisburg, over to Philly, and everywhere in between. So we're excited.
This is great. I'm thrilled for you. And you founded the option group 10 years ago, and like most of us who have founded companies, you're working out of your home before it was something that we all did. And I know you grew this practice with everybody in your house, and so I know you're thrilled to now have some office space. And it is interesting how, while many of us are working from our own individual homes, when you have a team working from your home, that makes it difficult to socially distance. So your new office is going to really help that. And I want to put a little commercial in here. Number one, make sure that you tune into our Friday events this month, because you're going to get to know more about the option group. But specifically on the 22nd, we were going to do a hybrid event where we would be doing it live and digitally from the option group offices. And because things have not sort of gotten much better with COVID just yet, we've got a real exciting way that you're going to be able to tour the option group offices on that Friday event. I'm really excited about it. So you're going to be able to sit right there in Ellen's office and chat with her. It's going to be awesome. So, Ellen, another thing I want to thank you for is that you and your team have been advising me on some topics and programs for this month. And I really want to thank you for, I've known Dr. Mansbach as long, if not longer, than I've known you, but for suggesting Dr. Mansbach, because he is truly a pioneer in the field and has a lot that he can share with us, as well as creating an engaging dialogue. And so this is for the audience. We want to make sure you guys ask questions, and let's make this very interactive. And so welcome, Dr. Mansbach.
Thank you. Thank you, Steve. It's good to be with you and all the participants who are on this call. And Ellen, I'd like to congratulate you. You and I have known one another for a long time. You guys do great work. I'm impressed by 265 years of clinical work. Now, I don't have 265 years of work myself, although I have to say there are days when I feel like I have, and this may be one of them. So what I'd like to do today is share some thoughts, kind of from a thought leader perspective, having spoken with many people in this country and in other countries about where we are. I think I'd like to blend sort of three topics and make this pretty interactive. I know there are a number of participants on this call who know the BCAT, who know me, and so forth. So I'll spend very little time talking about who I am.
Yeah, but yeah, before I'm psyched and I want to slow you down, Dr. Mansbach, but yeah, before we jump in, let's get to know you a little bit better.
Okay.
So give us a little bit about your background. And a lot of people are familiar with BCAT, but I think there's a lot of people that aren't. So
Sure.
give us a little overview.
Sure, happy to, Steve. My background is in geriatric neuropsych. I come to you with many years experience as a clinician, as a researcher. I founded in 2006 the BCAT Research Center. We developed the first BCAT test. Many of you actually use BCAT tools, BCAT tests. We evolved into what we think of at BCAT as a cognitive ecosystem. This is an integration of many different cognitive assessments, some mood assessments, and tests that are very predictive. We've created over the years a number of different evidence-based interventions with a lot of work on working memory. Working memory exercises are really critical for maintaining function and keeping people out of hospitals, all kinds of different outcomes. So we spent a lot of time on the science of that. I would say in the last 2 or 3 years, we've spent even more time on Alzheimer's and dementia mitigation strategies. Many of you know of the enrichvisits.com website. Enrich is a program. I'll talk briefly about it today in my conversation with you. Because it's really a way of not only lowering risk for Alzheimer's disease, but in this time of a pandemic, it also is a way of improving mood functioning. And I'll share some of that science with you today. So one hat that I wear, of course, is a research one. Some of you may know me also as the CEO of Counterpoint Health Services. It's a clinical company. We provide care in about 135 or 40 nursing homes, senior living communities, mostly in Maryland and in Northern Virginia. So I've offered books and some of you have read them. Maybe some of you have read our research papers. Perhaps if you have difficulty sleeping at night and you haven't, we can suggest some for you to read. But we really do believe that the best approach to memory care is to start with a scientific foundation. And so with that in mind, that's really who I am.
Oh, great.
And so maybe to help this conversation, Steve and Ellen, I'll bring up a PowerPoint, not so much for this to be didactic, but maybe it'll just kind of keep us on point for what we might want to talk about today. So I'm going to do that.
What Ellen and I are going to duck behind the curtain here and let's see, I am going to, that looks good. And then before I kind of duck off off my mic, I just want to remind the audience, type in at the bottom any questions as we go along. And Dr. Mansbach, if it's okay with you, I'll break in if there's a relevant question to something that you just talked about, and then we'll tackle the remainder of the questions when you're through.
That's great. I appreciate that.
Great.
So we'll make this kind of a open format here, but I'd like to talk to you about what we are describing as the social distancing axis. And what that really is about is, well, what are the unintended consequences of social distancing? Clearly, we know what the intended ones are. This is to slow down or lower the spread of the novel Corona-19 virus. But there are consequences to that. Many of you know it subjectively, but we'd like to talk about some of the science around that. I'd like to talk about healthcare providers and the impact of COVID-19 on them. We're going to define that in terms of psychological burden, which is really nothing more than collection of symptoms or indications of anxiety and depression that are significant enough to interfere with everyday functioning. We've been collecting data on this with providers since April of last year. And in fact, I'll talk a little bit about a survey we're planning to do, national one, with some of our partners, in February. It might even come out in late January, but probably early February. So we have another data point. But you know, it's important to talk about what we can do about these things when we are feeling burdened by the situation that we are in. And everything that I'm going to talk about today, as it pertains to you, if you're a healthcare provider, also is pertinent to the patients or residents you take care of, and certainly their families. I've spent a lot of time in the spring and early summer last year working with families associated with senior living communities and SNFs, kind of dealing with the pandemic. And they taught us a lot, actually, about coping and not always coping so well. If we have time, I'll talk a bit about ENRICH. This is a brain health program, evidence-based, but mostly in the context of improving cognition and mood. I'll introduce the M5. Some of you know about the M5. This is a free online psychological burden scale. It's getting a lot of attention now. I might talk a bit, if we have time, about my MemCheck, which is a free cognitive self-assessment, and why during the pandemic this is really important. So with that in mind, let's just do an overview on COVID-19. We all know this, so this is kind of a starting point. So what we know is that this is truly the greatest global public health emergency of our time, of the century, not just century starting in 2000, but in the last 100 years. We have to go back to the Spanish flu before we had anything quite like this. And of course, there are associated risk factors. So people who are older or more at risk, certainly those who have comorbid conditions, and we know what all those are, I think, at this point. Especially for those of you who are working in long-term care settings, senior living settings, nursing homes in particular. Healthcare providers at almost every level are at higher risk. We understand that now. And older adults themselves account for 80% of all COVID-related deaths. And we know that a lot of these deaths are concentrated in long-term care settings. Now, I'll talk today about psychological burden associated with COVID-19. I'm not going to talk very much about the somatic elements of COVID-19 from its symptoms standpoint. I think we know that. But that's kind of really not what we're going to focus on today. I do want to make a point for you, though, and I think this will resonate with you, and that is, and we started talking about this in April and May on a number of national calls, and it's simply this, that there's a metaphor for understanding COVID-19 from a psychological perspective. We use the war metaphor, and the reason why is that this is about PTSD. One of the things that we're really concerned about is 10 months into the pandemic, we're losing a lot of people at all levels, from GNA, CNAs to docs, to nurses, to rehab specialists, to behavioral health providers, and so forth, who don't want to do this work anymore. Partly it's the burden of doing the work, the anxieties associated with it. And if you think about PTSD, what you realize is that it's not just dealing with the current situation, it's dealing with the triggers that occur long term. So one of the concerns that we have is, how do we get interventions to people now to kind of ward off what might happen later? So I think many of you are on the front lines. Sure, some of you are doing work virtually, maybe through telehealth and so forth, but you're still in the game. You're still in this world, and you have a higher risk for psychological burden. So I'm going to come back to that from time to time, but I want you to think about that as a paradigm for COVID-19. Now, clearly, in addition to PPE, one of our interventions has been social distancing, right? So the idea is that if we create a social distance, we're making it harder for viral transmissions to take place. And, this certainly makes a lot of sense. So we can lower COVID-19 transmission through social distancing. But as we lower the ability of the virus to spread, we're increasing risk both psychologically and somatically. In fact, you can see this as almost inversely related to one another. When one goes down, the other one goes up, or when one goes up, the other one goes down, if you want to think about it that way. So I think it's a fundamental trade-off in some ways. So, you know, what do we know about how social distancing can be harmful? And let me be really clear, I am not in any way suggesting that we shouldn't social distance. Actually, quite the contrary, we should. But we shouldn't leave it at that. If we social distance, we must add meaningful engagement kinds of opportunities. It's very important because if we don't, those people who are more isolated are going to have more difficulties. And I think we know this in our regular lives, not just in our healthcare lives. So we should be thinking about this in terms of the patients we take care of, but we should be thinking about it in terms of ourselves, our families, and our friends. So why is this? Well, we're social beings and we need social engagement. Meaningful engagement, which can be defined really as a social activity where a sense of identity or belonging takes place, where memories are triggered, where we have more or less a meaningful experience. These kinds of opportunities are important to our health. Clear science on this. And some of the science in recent years has come from, some of you may know these books, the MEMPICS Project, which is a series of meaningful engagement books. Early studies that were done at our place at the BCAT Research Center were funded by CMS, used actually a lot in nursing homes and senior living communities and at home in the community, particularly for people who have cognitive impairment, to improve engagement. So we know that engagement is really critical. And when engagement falls below a personal threshold or baseline, we have physical or somatic and psychological symptoms. They begin to emerge as a function of time. It's kind of elegant to look at the science on this, because what it shows is that, you know, maybe in the first week or month, people kind of deal with social distancing okay, but over time, if they don't have opportunities to engage, then we begin to see somatic issues like more headaches, back pain, GI distress, and especially insomnia. You know, sleep disturbance is now emerging as one of the top 2 or 3 indications of burden associated with COVID-19. At the same time, when we are stressed, we release a number of stress hormones. This is not a conversation in neurophysiology, but I do think it's interesting to look at what happens with sustained stress. So clearly the pandemic, I think we could argue, the pandemic in combination with everything else which is going on in this country has created all kinds of releases of cortisol. This is in our body. When cortisol is released in a short-term basis, it's good. It's like that flight or fight response. But when you sustain cortisol release over a long time, things happen. It weakens your immune system. Well, that's not good when we have a pandemic. It can create heart disease or heart complications. It increases blood pressure. For people who are more at risk for type 2 diabetes, you would be worried about cortisol elevating naturally occurring blood sugar. Digestive systems, we get stressed and we begin to have GI distress. PPIs and other kinds of H2 or H2 blockers, other kinds of acid reflux medications. If you look at the number of over-the-counter sort of stomach or GI distress medications that are purchased, they're up about 35%. It's kind of a lot. Nerve problems can happen. And I think what we think about a lot on, is what's the impact of anxiety and depression with elevated cortisols, because it makes it worse. So what do we already know about the science? So we did a study at the BCAT in April and a little bit into May, where we measured psychological burden. So what we tried to do is we measured it, from healthcare providers representing many different disciplines. So we looked at physicians and nurses in primary care. We looked at behavioral health, which were psychiatrists, psych NPs, psychologists, social workers. We looked at rehab therapists, PTs, OTs, speech. We looked at nursing staff in homes. We looked at actually leadership and management in senior living communities. We also looked at families. So that data set was a little bit smaller. But what we found in April is that psychological burden as measured by the M5, which I'll describe to you in a little while, was reported to be at 40%, as opposed to the normal baseline, which is closer to 25%. So for, if you sort of average or take all together healthcare providers, the psychological burden registering that they had one that interfered with daily functioning was 40%. That's pretty high. We did it again in September and it didn't move. It was still at 40%, which tells you that it didn't get better. Now, remember, in April and May, there were a lot of unanswered questions, a lot of anxiety about what was really happening here. So burden did not improve. So the question now is, will we find that psychological burden in healthcare providers will go up or go down or stay the same in February? So stay tuned and we'll be able to share that information. And one of the things that I'll remind you at the end of this call, if you're not already a member of BCAT, it's free and it's an educational forum. You just put your, you just register, put your email address and your name. We don't share this information with anybody else, but you'll routinely get science-based and other information from us, including, for example, this survey that we're going to do in February. And you can do it in two ways. You can go right on the BCAT website, it's www.thebcat.com, and just register there as a member. Or you can go on the ENRICH site, which is enrichvisits.com, and become a member that way if you'd like. Now, families and residents, they were pretty similar in their psychological burden. Families were slightly higher. So you're looking at 50% or a bit higher. Ranges were really about 50 to 55%. Again, this is much higher than baseline. So it tells us that we can think about COVID-19 not just as a medical or somatic illness, but also as a psychological one. So what does that mean? I mean, what do we do? Well, I think it tells us that we need to screen ourselves and screen other people to see if indeed our indications of burden measured by anxiety and maybe depression are high enough so we can do something about it. Screening should lead to assessment, which is a little odd to have this conversation with you because many of you do the assessment. But, you know, it's sort of, you know, healthcare provider, help thyself. You have to begin with yourself. And so I'd like to share with you kind of a way of doing it. Now, for those of you who use BCAT, you're used to assessing, let's say, mood through something called the BADS, the Brief Anxiety and Depression Scale. It's part of the suite of tests that we have as part of the BCAT test system. And you're going to find that the M5 is similar to that, not quite as powerful as a predictive tool, but nevertheless useful. And if you want to check it out, even while we're talking, you can go right to the website. You can check out the M5 now. And although I would encourage you to wait, because I'm going to show you some of the things that you're going to see on the website right now. So first of all, the boring part about the science of the M5. It's got very high sensitivity and specificity. What does that really mean? Well, it means that if indeed you have psychological burden, that would be elevation in anxiety and depression symptoms, the M5 is, you have a 92% probability of identifying it, if indeed you really have it. So in this case, we're going to focus mostly on sensitivity, specificity. Basically, is a way of measuring error. That is, it will tell you how accurate it is if you don't have it. But we're going to focus on the 92%. Both of these figures are quite high in psychometrics. You should also know that you could use the M5 if you wanted to administer it. You can, a patient can take it themselves, family member can take it, you can take it or whatever. But if you wanted to use it in clinical practice, you could, and you can do it in person or in telehealth. So we did a study, which will be coming out, that demonstrates that there's no difference in efficacy. So you can do it either way. It's a perfect tool for a virtual visit too. No difference if it's self-administered in terms of accuracy or administered by you guys. If the patient is MCI or normal, and actually the data now would include people with mild stage dementia. It's not the case for people who have moderate to severe stage dementia, but for those of you who use the BCAT, if you had a score of, let's say, 34 or higher on the 50-point scale of the BCAT, then that person could do the M5 whenever they wanted. And if you did it initially with someone, or even if you did the BADS initially, and they were monitoring themselves afterwards, they could do so pretty reliably if their scores were that high. So nursing home residents had higher M5 scores than senior living and community residents. This is interesting. What it means is that the burden for nursing home residents has been higher than it has been for senior living residents or people living in the community. But let's not forget that those people in senior living and community also have high M5 scores. So it's a relative thing. M5 has no bias for race or education or marital status. And as I indicated before, there's really not a cognitive level bias. If people do it themselves, as long as they are above moderate stage dementia. But if a healthcare professional administers it, there's no cognitive bias across the cognitive levels. However, if you're working with someone with moderate to severe stage dementia, you would need, by proxy, an informant to ask. The M5 can be completed in less than 1 minute, so that's not going to take very much of your time. It was vetted, created, developed, validated specifically with a COVID positive population, although it's been cross-validated with those who don't have COVID-19, of course. It's adapted from the BADS, so those of you who know the BADS will recognize some similarity, although they're not the same scale. It's unique in that it does cross the kind of the mood spectrum. You've probably heard me talk about this before on other webinars. We think about mood, we think about anxiety and depression as sort of the mood siblings. So it's important that you have a scale that does both. I know in nursing homes and the MDS 3.0, you have the PHQ-9, not a great scale of depression, but at least it measures depression, but there's nothing that measures anxiety. It's why the BADS is really good in those kinds of settings. And as I said, the M5 could be, because it can be accessed online, it can be self-administered. It can be done kind of whenever you want it. Now, if you do the M5, you should probably know that scores of 3 or higher, that's the cut score, they indicate that there could be an issue. Now, it doesn't mean that you're clinically depressed, clinically anxious, and you need to go on an SSRI if you're not already on one. It does mean, though, that over time, if you don't do anything, you're more at risk for developing a more disabling mood state. I will say that, at the BCAT, when our team first took the M5 themselves, to a person, everyone had an elevated score. I hope if they take it now, it's lower, but it just, I point that out because I don't want you to be particularly anxious if you say, oh, my M5 score is really high. You're living in a time of high stress, but it should be a reminder that there are things that you can do to lower your stress and to do some health promoting activities. This is basically what it looks like. This is an adaptation of it, but we ask questions around a question about anhedonia. That would be losing interest in activities you had found pleasurable. We ask about worry. We ask about depression in a subjective sense for at least 2 consecutive days. We talk a little bit more about anxiety, and we have an item about, it's actually a conflation of somatic symptoms and memory symptoms. So you do this online and you get a score and so forth. Now, this is fine, and you can do the M5. And if you're worried, by the way, that in addition to mood or outside of mood, you're concerned, or if you think your patients express concern about cognition, you can do obviously BCAT testing, but for yourself, you can do something called My Mem Check, which is a cognitive self-assessment. I mentioned it 20 minutes ago, I guess, in our conversation. That's also available on the enrichvisits.com. My MemCheck's a peer-reviewed, published, brief cognitive self-assessment. It doesn't have the power of BCAT. It's not a diagnostic tool. It's the BCAT's a cognitive test. This is a screening tool. But it's just as powerful as the MoCA, as the SLUMS, and more so than the MMSE. It's used increasingly in primary care, and you might want to include it in kind of your toolkit also. So I would encourage you to go to the ENRICH website and try it out. Now, ultimately, the ENRICH website is created to give people kind of a way of thinking about how they can improve their brain health, but at the same time improve mood functioning. So the science of ENRICH really started well before the pandemic. What we found during the pandemic is that when you do these 6 things, ENRICH is an acronym representing 6 brain healthy behaviors that have the best science behind them. Look, you could do 10 or 12 different things, but not very many people are going to sustain that. So these are 6 important things to do. What you find is that not only do you mitigate risk, improve mood, but during a high stress time like COVID-19, what we found recently is that if you have normal cognition, if you have mild cognitive impairment, if you have mild dementia, and in some cases, even with moderate stage dementia, practicing ENRICH, particularly the cognitive stimulation, which I'll spend a little bit more time on, you actually improve M5 scores. So this hadn't been reported before. It's sort of, I think, the first science on this. So it's important to get the word out. So exercise daily. This doesn't surprise anyone on this call. And in fact, what you could do for yourself or for your patients is on the ENRICH Visits website, there's a free, what's called ENRICH calculator. I would recommend that you try it if you haven't done it. What it will do is give you kind of a scorecard of how you're doing right now, or these days, in terms of these behaviors, and it kind of puts you as a risk category. Now, the risk categories in terms of developing over the years, Alzheimer's disease and related dementia, but you can use it really as a proxy for how am I doing in terms of regulating my mood right now. I think that's rather important. Exercise daily. We recommend, 5 times a week, 30 minutes would be good, at least moderately challenging exercise, no smoking. That, again, won't surprise anyone. R is for routinely adding cognitive stimulation. That's challenging. This takes us back to working memory, which I'm going to come back to in just a moment. Why that's important: improving mood functioning, very critical, anything that you can do. Cognitive stimulation is one way of doing it. But remember what we said with social distancing. The more social distancing you have, the more at risk your mood is. The more at risk your mood is, this is a risk factor for cognitive issues as you age. The 2 kind of metabolic variables in ENRICH. C is controlling hypertension and heart rate. Again, that won't surprise you. You've probably heard me say this before, but even illnesses like Alzheimer's disease are probably, well, one, it's not one monolithic illness. It's probably a family of illnesses or sub-illnesses, if you like. But almost all of them are probably have a vascular link. I think. So hypertension and heart rate are important. Healthy weight and body fat's clearly important. I've been talking about this a lot with type 2 diabetes. But let's focus on cognition for a while.
Hey, Dr.
Yep.
Mansbach,
Yep.
I figure I'll break in and there's been some good questions, but especially Vincent Kobayashi has really raised some interesting points and addressed some conversation. But he has one question. It's how has the psychological burden impacted care or the perception of care from the resident's perspective?
So I want to make sure, Vincent, I understand your question. Let me answer it in two ways, and then you can tell me if I have this right. So one thing that we know is that when staff have high psychological burden, it's harder to be effective in their work. We even have an indication that high psychological burden is associated with a withdrawal from patient care. People, not saying that they're not trying to do the right thing, that they don't care about their patients. I mean, clearly people do, but it's harder to engage patients, and many patients who are cognitively intact or reasonably so experience this, and they can be negatively impacted. At the same time, you have residents themselves that have high burden, right? They're very anxious about what's going on with the pandemic. They may be seeing staff as a vector of disease, as someone who can infect them in some ways. And finally, and I don't think we can overemphasize this, for residents who have dementia, wherever they live, nursing home, senior living, at home in the community, they need other people, caregivers, healthcare providers, family members even, to engage them, because unlike the rest of us who could, if we remind ourselves, seek out meaningful engagement, people with dementia don't have the cognitive, because they don't have the prefrontal or the neural circuitry to initiate that. They're going to be more at risk. So if people withdraw from them, they're going to get more ill. So Vincent, I don't know if that answered your question. And if not, I'm happy to be a little bit more specific if I can.
Well, he does have a follow-up. That was really good. But does the increased anxiety have much impact on the immune system?
Does. So there's a direct link in acceleration in subjective anxiety and less efficiency in the immune system. And of course, we've known this, before the pandemic, but it's illustrated even more. So yes, sustained anxiety compromises the immune system and makes it more likely, not just that you would be a person's at risk for COVID-19, but for all the normal stuff we get, the normal colds. And think about this, we're in the middle, aren't we, of respiratory season. So anxieties about COVID-19, oddly enough, put us even more at risk for not just contracting, but having a more severe expression of other diseases like pneumonias, colds, things of that sort.
Yeah, and a couple of other comments I just want to draw attention to, and then we'll get back to but Beverly Bugos, she lives in a building that has 5 COVID positive residents, and they've been told to stay home. And she's just sort of talking about that, even though you're in sort of an environment where there's other people, if you've been told to isolate, these issues can arise. The other comment I wanted to draw attention to was from Barbara Sullivan, who's the director of the Village to Village Network. And she's sort of referencing how, a lot of the research that you're citing is in reference to people that are living in congregate living or senior housing environments. But, those elders that are at home and isolated, are you aware of any research or any details on that audience?
Yeah, we have some. So It is true that a lot of the science is focused on congregate housing, or people who are living together sort of under one roof. But the psychological burden data as it pertains to people living at home in the community, I mean, their elevations are also really quite high. So I think that 40% mark is on the mark kind of across the residential continuum. You have so many people who are isolated in all these residential domains. So the risk factors, I think, are pretty much the same, and maybe in some cases worse. So, you know, if you're in a program where you're able to reach out to people who are living alone and who are at risk in the community, I mean, that's really important. But in addition to the work that you do, it would be important to add meaningful engagement opportunities. Whether you're working with people who are cognitively intact, if they have MCI or if they have dementia, it's important. And if you're working with people who have dementia, you might want to do programs like MEMPICS, because you can do them in person, but you can do them virtually as well. It'd be very important. Yeah, it's good. It's a good comment and a good question.
Great. Yeah. So didn't mean to derail you there, but I wanted to make sure that we address those and make sure that everybody knows that they can ask questions in the Q&A. All right.
Yeah. So, and Steve, how are we doing for time? Just so that I know, I want to make sure that we have time for questions in the end.
It's about 15 minutes to 1 right now. We usually try to wrap things up at 1, but we can go longer if your schedule permits. And just a reminder to everybody, we record this, so if you have to drop off for any reason, we'll send out the recording.
So there's a fair amount of science on working memory exercises now, and this science pertains to people regardless of where they live. So SNFs, senior living, at home in the community, and so forth. So an interesting dynamic takes place. So working memory, just to be sort of technical for a minute, so we're all talking about the same thing. I mean, this is, we talked about this, Steve, you remember this book that I co-wrote on brain health as you age. We talked a fair amount about this cognitive task manager. So working memory involves attention, and involves memory, and to a certain extent, these executive functions. So the idea here is that working memory is the ability to sustain focus long enough to learn something new. And it's actually, in terms of neurophysiology, it sort of underpins our ability to even do everyday activities of everyday living, even instrumental or more complex ones. So what happens is that when people develop, let's say, memory disorders like Alzheimer's disease or things like that, their working memory is compromised. But an odd thing happens with sustained anxiety. And in sustained anxiety, the efficiency of working memory is also impaired. So what that really means is that working memory allows us to basically function. So we want to do everything we can to strengthen working memory, to be more efficient with the working memory that we actually have, and to try to keep it from degrading in some ways. So from an empirical standpoint, when we do working memory exercises, these are the things that happen. If we do them routinely, let's say 5 times a week, that's quite good. But what happens is that we lower our risk for illnesses like Alzheimer's disease. And probably because we push the onset date. So rather than developing at 75, maybe it develops at 80 or 85. Maybe the rate, or what we call slope, but the rate of decline might be less severe. But we also see a clear link between cognitive exercises, particularly working memory ones, and mood functioning. That is, mood tends to be better, and it tends to improve, well, it improves specifically depressive symptoms, and anxiety symptoms. So the trick is to do working memories that have science behind them, because otherwise it's just an opportunity risk. So there's nothing wrong with doing the New York Times crossword puzzle or anything that you like or that your patients like to do. That's fun, that's good, you should do that. But they're not all the same in terms of their efficacy for working memory. So our team has spent an awful lot of time over the last 10 years and trying to figure out what works and what doesn't. So some of you know that we have some brain rehabilitation modules online. You can check them out if you want on the BCAT website. But you know, there are only 3 in there as opposed to 10 or 20 or 50, because we couldn't find evidence that the other ones actually work. So same thing with the working memory exercise books. I know some of you use them professionally. And then the home edition that patients get for themselves or consumers get for themselves. You know, it took a really long time to go through those protocols because a lot of these so-called working memory exercises just really don't work very well. And by working, you have to demonstrate in the science in a randomized experimental design that they improve cognition relative to placebo, and in some cases to other kinds of exercises. And in our case, the thresholds were improvement in cognition, but also improvement in function. So you want to make sure that people are actually able to live better. So, you know, being able to remember something objectively is great, but remembering things in real life is, is even better, I think. So we're going to say to you, if you're trying to take care of yourself, do the M5, do the enriched calculator just to see how you're really doing with all this stuff. Practice modifiable behaviors. The M5 will kind of tell you, what you should be working on. Take my mem check as a cognitive self-assessment if you want. But if you had to focus on 3 things, 3 most important things outside of the metabolic stuff, blood pressure and healthy weight and all that sort of thing, they would be, physically exercising, cognitively exercising, and improving opportunities for meaningful engagement. I think those are kind of the most critical things of all. Now, I'm just about ready to get into sort of a Q&A with you, and I'll take down the PowerPoint. But before I do, I want you to know that we're going to be introducing a new certification in 2021. And we're calling it the Certified Cognitive Specialist. And it's kind of a master clinician distinction, although you don't have to be a clinician necessarily. And what this really does is, and it's specific to, you can become a certified cognitive specialist if you're in behavioral health. You can become one if you're in rehab. You can become one if you're in geriatrics. There are a number of different distinctions. But the idea is to go beyond dementia. I mean, dementia is important, and we spend a lot of time in training people in dementia. This program is very evidence-based. You will obviously learn a lot about dementia. You'll learn a lot about cases. You'll learn a lot about the science. You should be able to apply it to any setting that you work in. But in order to really make this work, you need to go beyond dementia. So there's a strong emphasis on mild cognitive impairment, now called sort of looking at the neurocognitive disorders a little bit more specifically. You'll be learning about risk factors for MCI from a IEDL, ADL, and somatic health perspective. It's a combination of blended learning. So there will be live training that's part of this. You'll also do some training, and some of the work, certification work will take place offline, on your own self-paced learning. So it's people who become certified cognitive specialists, if they're not already BCAT licensed, that becomes part of, you get that. get a lot of collateral materials, but you also get to participate in an ongoing educational series that other people don't have access to. So stay tuned for that. We'll be messaging that when that is ready, but I know that there are people on this call who will want to do that. We will also be, well, I said that I would just remind you that you can become a free BCAT member so you know what's going on. That would be really important. I'm also going to, for some of you, it will be a reminder. We at the BCAT did, in concert with Counterpoint, we did a fall webinar CEU series. We had 4 programs. We did talk on webinar on depression, depressive disorders, one on anxiety disorders, one on psychotic disorders, and one on personality disorders. They were very well attended, and so we were encouraged to do a spring series, and we will do so. So stay tuned for that. I know that one of the programs will be specifically on social distancing. We will be including data from the survey that we have. Any of you who want to participate in the survey on how healthcare practitioners are doing, it's completely anonymous. And we also ask a lot of questions about the vaccine. We're really polling, surveying people how they really think about the vaccine. And this is important because, I mean, for many reasons, but one of them, and I'll put it into sort of a question format, and it's simply, what does it really mean to have a vaccine available from a psychological standpoint? And in the next 3 months, do we think that it will add, subtract, or have neutral impact on psychological burden of providers and the patients that they're taking care of? So I'm going to pause here, Steve and Ellen, and we can go into Q&A. Any questions that we have, I'm happy to respond to.
Great. Yeah, we've got some questions, and like I reminded everybody, we'll get through these. Probably go a little bit over 1, but what we'll send you the recording, as well as Dr. Mansbach. We've had a lot of requests for your PowerPoints. Could you email that to me, and then
Sure.
I'll send it out? Okay, great. So let's see. Samantha asks, regarding the working memory exercise book, is there an app available to purchase or download so someone could do these memory exercises on their phone or other device?
Mm-hmm. Currently, there is not. There's a lot of discussion about doing that. And because we are increasingly digital, that will likely happen. But so many people like to have the book. I mean, this is sort of an interesting thing among many of our patients and consumers, but increasingly, it's sort of interesting, people are doing working memory exercises at younger and younger ages, and so more likely to have a digital format. So not yet, but that is something that's in discussion.
Oh, and before I jump into the questions, I think, one of the things that you're talking about is, we've all got clients, and they're going through some real challenges here, and just nice little gestures or things that we can do to help engage. Ellen, before we got on the call, you were sharing with me something that you and your staff have done to help engage your clients and brighten their day. You want to share that?
Yeah, sure. As care managers, we work with folks who are in facilities or in homes and are very isolated. So we're seeing all the things that Dr. Mansbach is talking about, and we do use his MEMPICS book, and we work with people to do engagement activities. But to celebrate our 10th anniversary, we have note cards made up with a little puzzle inside, a little word search with some kind of words that they can try to, use the brain. And we're inviting people to join us, and we are just writing these notes out and giving them to people who might be isolated, whether it's a family member, a friend, a client, somebody who might be just isolated. And it's kind of like a virtual hug, since we really do need a distance, but it's a way to kind of add another way, a meaningful connection with someone. So if anybody's interested in doing that, contact us, and we'll share our note cards.
Great. I'll be sending your contact information out. And I think it's also a good reminder for those of us who are providers on the call is that we've all moved to such a digital world. Trust me, I'm in the middle of it, with these types of events. But it really speaks to the fact that, we all still beam when we get that handwritten note in the mail and you open it up and you just feel like somebody spent some time and they care about you. But then to have a little brain puzzle in there is not a bad idea. So hats off to you on that one. Beverly Bugos says, is there any correlation between IQ/EQ in the exercise books? Does the level of intelligence require different exercises?
So I mean, this whole idea of intellectual abilities, emotional IQ, things of that sort. I can't say that there's a differentiating, sort of like, well, if your IQ is X. I mean, basically, this is the working memory exercises are laid out in progressive difficulty. So they're really pitched at people at all levels. So you can have moderate dementia, or you can not have dementia, but not be, not have a particularly high IQ, and you can still benefit from these exercises. And in fact, in the working memory exercise home edition, there's something called taking it to the next level, which is, we have a lot of people who want to do this who are perfectly intact and they want the most challenging exercises, and it makes it more challenging. And many of these people had asked, okay, I know we can get these books on ENRICH, where else? So we actually did what people do now, which is you can go to Amazon and you can get these books. You can get Mempix on Amazon too, as it happens. It's an interesting question.
I put the links to the books in chat. I'll be sending them out in the email as well.
Thanks.
Let's see. Vincent asks, can meditation, mindfulness exercises have much impact on this?
Yeah, so I'm going to say, is it possible to go above 100% as an endorsement? So, meditation is parasympathetic, which means that's the quieter in the body. I'll tell you, it's remarkable that if you think about it, if you think about mood physiologically, that's a lot about serotonin, and that's actually made in the gut. It's actually not made in the brain. We have two brains. We have a gut brain. So we do this talk on sort of the two brains, how they talk to one another. So really very briefly, the microbiota in the gut regulates how much serotonin is being increased. Meditation actually quiets the gut. It actually promotes a more release of serotonin. More serotonin is a quieter. So meditation is important. Meditation, and it doesn't have, you don't have to be perfect at it. You can do it, lots of different ways of doing it. But yes, I think anything that's parasympathetic. Sympathetic would mean that's what revs your system. If it's sympathetic, there's cortisol. Parasympathetic means we're going to just quiet it all down. So yeah, a little bit of red wine can be good too, in moderation. So lots of things that you can do.
You're going to have no complaints there. Okay. Vince, let's see. Vincent also asks, how often should these exercises be done, and when during the day or the week can they be done on the fly, meaning quickly, or even made fun?
I think they are fun. I mean, part of their creation was to make them fun. So, and they're very different. I mean, they're ones that are, we had to create, when we first created these, many of these just did not exist. And then we had so we had this great sort of series of conversations, and we had a lot of people involved from rehab and neuroscience and social work and all kinds of different things to make this happen. So I think they are fun, to tell you the truth. You can do them at any time. We like this idea of 5 times a week is the optimum, 3 times a week is good. But you know what? It's duration too. 10 or 15 minutes is fine. There's no indication that doing it hour after hour on a given day is any better. So it's good. I mean, you don't have to do it very long. You just have to do it.
Great. Let's see. Somebody asks, is it possible to see a demo of the cognitive tasks and exercises that are most effective for working memory?
Yeah, so we can, we have videos that kind of go into that in a little bit more detail. So yes, and the way to find out about that is to email us info@thebcat.com, and then that's a email that gets monitored every day, and anyone can ask a question through that. And in fact, we have a series called Dear BCAT, where these questions come in from all over the country, all over the world, and so we put out responses, and many of them are video responses. So if you sign up, you'll actually get some of those as well.
Great. Ada says, at what stage of memory impairment does the working memory test help decrease the slope of memory decline? And has it been shown to improve memory decline in Alzheimer's dementia clients?
Yeah, so the sweet spot for working memory exercises in terms of their efficacy is MCI and mild dementia. So there's clear evidence that people get better, both cognitively and in terms of their functional performance, let's say at home. I will say that there is no differentiation between Alzheimer's disease and several other diseases that cause dementia, like Lewy bodies dementia, frontal temporal dementia, and things of that sort. I'm not saying that in theory they wouldn't be there. We just haven't found any of them. So we talk about it in terms of dementia as kind of a category rather than being more specific. Now, I am going to say to you, there's no evidence that people with the bottom end of moderate stage dementia, but mostly people with advanced or severe stage dementia, there's no evidence that working memory exercises, ours anyway, frankly, anyone else's that I've seen, improves cognition. So, if you use BCAT or something like that and you have severe dementia, I'm not going to recommend you use working memory exercises because I don't think they'll work. I think Mempics will work, but I don't think that working memory exercises will.
Great. A couple more questions and then we'll wrap things up.
Sure.
Okay. Martha Cooper asks, any study of COVID patients' cognitive impairment?
Yeah, so there's a lot of that's emerging. We have data that we're going to be releasing that's emerging. Some of this is in cooperation with our sister company, Counterpoint. So one of the Dear BCATs that we did was, the question was this: is it true that COVID-19 represents a risk factor for sustained cognitive impairment? So I answered that several months ago and said there's not enough evidence to say one way or another, and I don't think that there is. I think, though, that there is a condition for some people. It's anomalous almost to chemo fog. I think that there's a COVID-19 cognitive or brain fog that emerges. I'm not impressed, though, that right now we can say that this is going to be a permanent condition. I can't say it is or it isn't, but there's no indication after 10 months that I've seen that I'm impressed with that this is a risk factor for dementia, for example, even though you can always find some article somewhere, usually in the paper, right, that says, oh, this is a problem. I haven't found evidence of that so far.
Okay. And then and the last question, and then we'll wrap things up. And I think Ellen may be able to make a comment on this, is that can these exercises be effectively administered by healthcare workers, specifically through video chat or engagement, or even done in a group setting? And I think I heard you say, Ellen, that you have utilized these exercises with your clients.
Yeah, we've done a combination of in-person outdoors or utilizing platforms like this, and we carefully pick the activities so it's something that's you can facilitate over a 2-dimensional rather than a 3-dimensional thing.
Great. Vincent, and thank you, Vincent, has been very engaging with your questions, and they've been very thought-provoking. He has one last question, and because he's been so interactive with us today, I'm going to say, any stats on how this can delay dementia?
You mean working memory?
Yeah, or I guess I'm assuming these exercises and the things that you've been talking about.
That would require much more longitudinal data. So I'm going to say that the science is not particularly strong, but it's not weak. It's just not been long enough, basically, to be able to say that. What I can say is that there's very clear evidence that it can delay transfer to senior living and nursing home. So from a functional standpoint, we already know that there's strong evidence for working memory. And we've published that actually in what's called the model is better, faster, which is you can improve cognition and function more quickly and more effectively through working memory exercises.
Great. Well, thank you. I know there's so much information here. You're such a wealth of resource. I will, as I had mentioned, I'll post all these links, the chat recording, contact info for Dr. Mansbach and Ellen, and we'll look forward to seeing everybody next week and throughout the month. We've got a lot of good programs planned.
Thank you for having me. I enjoyed it. Looking forward to talking to you the next time.
Okay, and congrats, Ellen.
Thank you very much.
You bet.